would the students like to start? Any particular character or theme you'd like to begin with?
I think definitely George with his arm and his, quote unquote involuntary movements.
So if there are people who are part of this group now who were unable to watch the episode, briefly, 25 words or less, I'm not going to put you on the spot. Somebody briefly describe the scene so we can actually begin to detail this.
So from my understanding, it was he nudged Jerry kind of to make a joke. And then the person that he was making fun of saw him and asked, "Oh, what's wrong with your arm?" So as an excuse, he kind of just said, "Oh, I have this, condition that makes it so that I constantly have to kind of nudge my arm."
So let's parallel this with clinical practice, where someone may tell you something that's part of what is referred to as the chief complaint. Now we're switching back to Seinfeld, the non-fat yogurt, when George begins to tell his story, what becomes evident with regard to its validity? I mean, it's easy, yes or no. Is it valid? Is it the truth?
It's very much not the truth, and the doctor immediately picks up on that.
Right. Right. And I'll make a comment about the astute physician in a little bit, but there is misinformation. That is, and let's make sure we phrase this correctly, that in this case, George Costanza's chief complaint is not readily explained by, in this case, neurophysiology or neurochemistry. Right? There's something with regard to physical exam findings and or laboratory workup that does not support George's story. Right? And again, there's a parallel with regard to medicine that kind of unfolds in the same way. And when a clinician hears an individual, a patient, tell them something that is inconsistent with the way the body functions, there are three things to consider. Okay, and we're going to get to the breakdown of those three things now. The first part of this algorithm, the first split in a clinician's case formulation is simple. Is there a conscious effort to deceive, AKA, are they lying or not? Right? And we already established that George is in the column, if you will, where we believe he's lying. So before we get there, let's talk about the situation in which the individual isn't lying, that you don't uncover anything with regard to your physical examination, including a mental status exam, or the patient's history to suggest that they're lying. In this case, you're dealing with what is referred to as a somatic symptom or related disorder, where somatic symptom disorder would be the easy example. And then there are some related disorders that should also be in your differential diagnosis. Anybody have any guess as to what related disorder the clinician should think of, or primarily think of in their differential here? It's called conversion disorder. Right. So a conversion disorder is a disorder. It's a mental disorder that is related to somatic symptom disorder. So whether we call it somatic symptom disorder, whether we call it conversion disorder, we are dealing with a situation in which the patient's chief complaint is simply not supported by any known physiology or obtained lab results. Anybody have a guess as to what differentiates somatic symptom disorder from conversion disorder? Conversion disorder is when the focus of the individual's chief complaint is on voluntary motor or sensory function. If the focus of the individual's chief complaint is voluntary motor or sensory function, we call it conversion. If it is anything else, we call it somatic symptom disorder. So in that way, conversion disorder can be looked at, can be viewed as a variant of somatic symptom disorder. It is a disorder, a mental disorder related to. Hence, it is in the chapter somatic symptom and related disorders. So those are two things I think clinicians should always think about. If this group had decided that George Costanza was telling the truth because of the involuntary muscle movement, his most likely diagnosis would have been conversion disorder, voluntary motor and or sensory function. On the other hand, you're telling me that the individual is lying. There's a conscious effort to deceive. Anybody have any idea of what the next question then you would ask George? Or in your clinical exam, what next you would try to address, even if not a straightforward question to the patient?
If he has any real motivation, like external.
That's it. Motivation in psychiatric or psychological terms is called gain, G-A-I-N. So motivation or gain would be the next best step. If the motivation is external, then we call it, or at least we used to call it, malingering. If it is internal, that is subconscious, or otherwise referred to as secondary gain, we call it factitious. So that's the differentiation between malingering and factitious. So again, external gain is malingering, internal gain, subconscious gain, secondary gain is factitious disorder. So by kind of going through the algorithm, by working this through the clinical mind, you could see that there are three sets of illness: the somatic symptom and related disorders, for which there are two primary examples, as well as other conditions, including factitious and malingering. So I think that's a three-pronged way clinicians should address situations in which people come to you and ask you for help, but physiology simply does not support what they are telling you in their story. That's exactly what George Costanza is representing today. Now, Larry David gives it away. We actually see, we observe everything unfold. And that's a reminder to clinicians, right? And again, we're talking about now the astute physician who picks up that George Costanza is lying and therefore is malingering. In the absence of observable evidence, unless you actually see the patient do something that they tell you they can't do, or vice versa, you have to give them the benefit of the doubt. So if you don't catch them in a lie, it is always a somatic symptom and related disorder, or to say, or related disorder. Even if your red flags are going up, even if you deeply suspect them to be lying, unless you observe it and are able to medically document it, they are not lying. So the default must always be the patient is telling the truth and therefore is always presenting with a somatic symptom or related disorder. If, on the other hand, you walk into the room and you see the individual doing something that they just told you they are unable to perform, and you actually observe that, then you can go to that proverbial second column. This then is factitious versus malingering. And as a viewer, as an audience member of Syfeld episode, The Non-Fat Yogurt, we see George actually do something and then lie about it. So we catch him in his lie. That allows us to discuss whether or not this is factitious versus malingering. And because in watching this episode, we understand that he lies to avoid embarrassment, given what he did, that is an external gain. And therefore, George Costanza is malingering. So there's your algorithm. It's very critical to understand this. And shrink this down to its basic components, because real life cases that present like this are awfully difficult. Very, very difficult. And even though I presented this as discrete entities, and even in the publication of the DSM-5, there are discrete pages, parts of chapters dedicated to this. The fact of the matter is that the lines between these are often blurred, especially when you're looking at motivation and gain. It's not usually binomial. It's not necessarily one or the other. Sometimes there's components of each that makes the clinical situation very confounding. Any other questions or observations about George Costanza and then on fat yogurt? What other character interested you in this episode? Anybody else?
Elaine and her like obsession with her weight.
Go on. So again, for those who weren't able to watch the episode, give us a little bit of detail about what you saw.
So basically, Kramer tells Elaine and Jerry that they look like they've gained weight, and then they go and weigh themselves, and it turns out they have, and they are very confused because they haven't changed anything about their diet or exercise routines. So they end up blaming it on the non-fat yogurt, and then becoming obsessed with figuring out if the yogurt actually has fat or not.
So if Elaine presented to you with these concerns, I mean, and these concerns were at the intensity that motivated her to seek help from a psychiatrist, right? Because she was preoccupied. What are some of the things that, as a clinician, you would have in your differential diagnosis? Anyone?
Definitely a preoccupation with weight and body image. She thought the reason she didn't get a call back was because of when the man put his arm around her instead of her almost getting him fired. So yeah, that was problematic.
What condition should we discuss then?
Body dysmorphic.
So that would be in the differential, body dysmorphic disorder. Body dysmorphic disorder, and again, this is, I'm going to approach this in a way similar to what I just discussed pertaining to the somatic symptom and related disorders. If an individual comes to you with a preoccupation with regard to their being disfigured in some way, body dysmorphic disorder must be high in your differential diagnosis. Body dysmorphic disorder is a preoccupation with an imagined defect in appearance. A preoccupation is a deficit of thought content, and it distinguishes itself from a delusion by its rigidity. That is there any insight to the individual's thought content versus not? If the individual provides some insight that the preoccupation, this thought, is a product of their own mind, and there is some discussion that you could have when presenting evidence to the contrary, we'll call it a preoccupation. However, even upon presenting evidence to the contrary, if the individual remains fixed in their belief, then we call it a delusion. And again, it sounds simple in terms of what I just told you, the definition, and how now you will approach this on a test, but in real life, it's not nearly as simple, because the line between a preoccupation and a delusion is not always clear cut. But for this morning, and our purposes, in this didactic, preoccupation, yes, insight. On a scale of 1 to 10, the insight is going, or I should say, on a scale of 0 to 10, insight that helps define a delusion or separate a delusion is going to be 0. And then looking at it from the other perspective, on a scale of 0 to 10, the level of insight that will help you differentiate the preoccupation is 1 to 10. So it could be extremely low, or it could be quote unquote within normal limits. If an individual comes to you with an imagined defect in appearance for which you deem there is no insight, and even when you present evidence to the contrary, the individual remains fixed in their belief, the most likely diagnosis then would be delusional disorder, somatic type. So on tests and standardized exams, delusional disorder, somatic type, and body dysmorphic disorder are usually found in the same answer set, choice A, choice B, when the clinical vignette has someone present the clinical practice with a chief complaint that is an imagined defect in appearance. When that imagined defect in appearance is body image, we call it eating disorder. So if somebody comes to you with an imagined defect in appearance and the focus is on their body image, we're going to call it an eating disorder. But when it's focused on anything else, we call it body dysmorphic disorder. It's a very similar way that we differentiate conversion disorder from somatic symptom disorder. Conversion, voluntary motor and or sensory function, anything else falls into a more of a grab bag category called somatic symptom disorder. And similarly, individuals who come in with a chief complaint of having an imagined defect in appearance, when the focus is on body image, we call it an eating disorder. Everything else is called body dysmorphic disorder. Before we get to the next step in terms of differentiating the different eating disorders, are there any questions with regard to anything we've previously discussed? So an individual comes in either through inquiring about and working through their chief complaint or providing the mental status exam or both. You believe that they have an imagined defect in appearance, and more specifically in body image. You believe that they have an eating disorder. The first step is to deem whether or not they have a fear of gaining weight despite being underweight. That's really where you have to go here. Because if the answer is yes, the type of eating disorder that is most likely to be the patient's presenting signs or explain the patient's presenting signs is called anorexia nervosa. If there is no fear of gaining weight, and if your patient is not underweight, the most likely diagnosis is going to be bulimia nervosa. So again, the easiest way to separate the two and come to the single best diagnosis of the particular type of eating disorder. Again, an individual comes in, you feel as though they are preoccupied, specifically with an imagined defect in appearance. If that defect in appearance is body image, eating disorder, and if there is a fear of gaining weight despite being underweight, anorexia, if not, bulimia. If the imagined defect in appearance is anything else other than body image, body dysmorphic disorder. So again, you can build the flow chart that way. All that said, while I think Elaine's behavior prompts this very discussion, it allows us to review the way in which we go processing or working through this chief complaint of a distorted appearance. I do not believe Elaine necessarily to have an eating disorder. I think bulimia nervosa was something that is diagnosable in a peripheral character in another episode, a date that George had, but not in Elaine Bennis. So definitely prompts the discussion, but I'm not sure I'm near ready to diagnose Elaine with an eating disorder. Any questions with regard to eating disorders or the character. So about 20 past the hour, probably have time for one more discussion on one last character. Anybody want to pick one?
Maybe Kramer and the way he was behaving to get his investment like protected after it could possibly be found out that the yogurt place actually does have fat, like the way he behaved with the lab technician.
So what are some other parts of Kramer's behavior that interested you or thought you deemed concerning in any way? Anybody?
He was constantly, well, he's the one that pointed out to Jerry and Elaine that it looked like they'd gained weight, and he was constantly calling them fat or chubby, kind of cruelly.
Yeah, this is another episode where Kramer demonstrates an incapacity to process social cues and things that many of us would deem to be culturally relevant with regard to interpersonal interaction. Kramer simply defies. And that might be the way he interacts with the lab tech, which is inappropriate. And it may also, that same motivation or that same behavior is likely what we're observing in his interaction with his friends. Now, I think at face surface, we look at his interaction with Jerry and Elaine, and again, I want to reemphasize that even though we pathologize things when we discuss situational comedies, we always have to consider, and I would expect the starting point should always be normal behavior, right? So they're friends, and sometimes friends talk to each other in a way that if we're a third person or a third party, we might raise a brow, but we have to respect that there might be some level of being familiar between those individuals that we are not part of, and we have to exercise unconditional positive regard. We can't be offended when we overhear or a third person hearing a dialogue that may have a content that we're not familiar with, but is familiar to the individuals within that dialogue. And that's possibly what's going on as we're viewing Kramer interact with both Jerry and Elaine. However, even though that's the starting point, the astute clinician will continue to observe, i.e. watch the remainder of the episode, to uncover evidence that there is reason to kind of gravitate from that initial perspective and begin to discuss that Kramer's beliefs, his behaviors, his thoughts are in fact pathological. And when we see him interact with the lab tech, and we see this interaction be in a different setting, we then know it's pervasive, which means that it's not state dependent and having to do with friends, that it goes beyond that. Now, the source or the origin of Kramer missing on social cues is suspect. We only have 5 minutes left. Suffice it to say, it's really beyond the scope of our discussion this morning. But you've heard me say before that I've always thought Kramer to be a cluster A personality. And certainly with the schizoid personality disorder and the schizotypal personality disorder, being socially isolated and even socially awkward at times can be seen in both of those. The other cluster A personality, specifically paranoid personality disorder, does not appear to be playing a role here. But I think if we were to have this discussion, we would certainly evolve to the cluster A personalities in general, and certainly differentiate between the schizoid personality as well, or versus the schizotypal personality disorder, because both have that difficulty with social interaction. And I think that's what's going on with Kramer. And even if we look at that N of 2, lab tech, friends, right, happens only twice. For those of you who have seen prior episodes and prior seasons, we know that Kramer's attitude, his behavior in these types of social situations is quite pervasive. And because we could date this all the way back to season 1, it's also stable, right? So it's stable over time, as well as being pervasive, that is, crossing social situations at any one point in time. and that's supportive of there being a personality disorder. Right? Non-personality disorder mental illnesses are usually defined by a change from previous functioning, not stability. So I think that's the way I would work through Kramer's behavior. All right, any last questions? Otherwise, we're kind of coming up to the bottom of the hour. Last questions, last thoughts? All right, we'll end it here. For those of you who are on the service today, there's only one team this morning.